When he was a surgeon at the Cleveland Clinic, Dr. Caldwell Esselstyn published a controversial paper in the American Journal of Cardiology. Heart bypass operations carry significant risks, including the potential to cause further heart damage, stroke, brain dysfunction. Angioplasty isn't much better, also carrying significant mortality and morbidity, and often doesn't work in terms of decreasing risk of subsequent heart attack or death. So it seems we have an enormous paradox. The disease that is the leading killer of men and women in Western society, Western civilization, largely untreated. The benefits of the invasive procedures are at best temporary, with most patients eventually succumbing to their disease. In cancer, we call that palliative care, or we just kind of throw up our hands, throw in the towel, and give up actually trying to treat the disease. So why does this juggernaut of invasive procedures persist? Well, one reason is that performing surgical interventions has the potential for enormous financial reward. That's considered one of the barriers to the practice of preventive cardiology, adequate return. Diet and lifestyle interventions loses money for the physician. Although the practice of preventive cardiology is not as lucrative, this article was hoping to nudge cardiologists in that direction by appealing to less tangible benefits. Another barrier is doctors don't think patients want it. Physician surveys show that doctors often don't even bring up diet and lifestyle options, assuming the patients would prefer, for example, to be on cholesterol-lowering drugs every day for the rest of their lives. And that may be true for some, but it's up to the patient to decide. According to the official AMA Code of Medical Ethics, physicians are supposed to disclose all relevant medical information to patients. The patient's right to self-decision can be effectively exercised only if a patient possesses enough information to enable an informed choice. The physician's obligation is to present the medical facts accurately to the patient. For example, before starting someone at moderate risk on a cholesterol-lowering statin drug, a physician might ideally say something like, "You should know that for folks in your situation, the number of individuals who must be treated with a statin to prevent one death from a cardiovascular event such as a heart attack or stroke is generally between 60 and 100, which means if I treated 60 people in your position, one might benefit and 59 would not. As these numbers show, it's important for you to know that most of the people who take a statin will not benefit from doing so, and moreover that statins can have side effects such as muscle pain, liver damage, upset stomach, even in people who do not benefit from the medication. I'm giving you this information so you can weigh the risks and benefits of drugs versus diet, and then make an informed decision." Yet, how many physicians have these kinds of frank and open discussions with their patients? Non-disclosure of medical information by doctors, that kind of paternalism, is supposed to be a thing of the past. Right? Now physicians are supposed to honor informed consent, unless the patient's in a coma or something, or it's an emergency. But too many physicians continue to treat their patients as if they were unconscious. At the end of this long roundtable discussion on angioplasty and stents, the editor-in-chief of the American Journal of Cardiology reminded the participants of an important fact to place it all in context. Atherosclerosis is due to high cholesterol, which is due to poor dietary choices, and so if we all existed on a plant-based diet, we would not have even needed this discussion. The total antioxidant capacity of our diet may also be protective against stroke, in contradiction to all the pill studies that failed to show benefit. But what they did in this study was to take into account all antioxidants present in actual food in the diet, including thousands of compounds and doses obtained from a usual diet, not one or two in high doses in pill form. Stroke is the world's leading cause of death after heart disease. The buildup of oxidized fat is considered the hallmark of fatty streak formation, the earliest manifestation of atherosclerotic plaques. Yes, the oxidation of fat can happen outside the body every time we cook it, But oxidized fats are not only formed in foods, but may also be generated during digestion, especially in stomach acid. Our stomach may be like a bioreactor for the oxidation of high-fat, cholesterol-rich foods. See, muscle foods contain large amounts of endogenous catalysts, which accelerate fat oxidation. As poultry sits in our stomach, the oxidation may build up minute by minute. See, chickens are bled of only about half their blood, and the remaining residual can be a powerful promoter of fat oxidation. So there are those in the industry advocating an additional decapitation step to reduce all that oxidation. But if oxidation is the problem, antioxidants may be part of the solution. Total antioxidant capacity from diet and risk of heart attack. Well, we know antioxidant pills don't work, while extensive experimental data have revealed a central role for oxidative stress in the stiffening of our arteries, and suggested a potential role for antioxidant treatment in cardiovascular disease. Experimental data has not translated into clinical benefit. Most antioxidant vitamin trials have failed to reduce heart disease and death, and may in fact even be detrimental. As a result, some have even questioned the supposed central role of oxidative stress in the disease process, described as a critical blow to the whole free radical theory of aging, the fact that pills didn't work. But high-dose single antioxidant supplements are not a good substitute for the very complex antioxidant network of thousands of compounds in foods, present at concentrations far below those used in the pill trials. No one had ever looked at the overall effect of the complex antioxidant network in diet in relation to our leading killer, coronary heart disease, until now. The total antioxidant capacity measures in one single value the free radical reducing capacity of all antioxidants present in foods and all the synergistic effects. And in this large prospective population-based cohort study, they observed that higher total antioxidant capacity of diet was associated with lower risk of incident heart attack in a dose-response manner, meaning potentially the more high antioxidant plant foods in our diet, the better.